So this video is going to be a bit of a ramble, hopefully a short ramble on the antidepressant drugs and in the UK which antidepressant drugs are commonly used and the order in which they would generally be prescribed. So which one is first line, which one is second line, third line, etc. So firstly then, let's just talk about what depression is. So for those who have never experienced depression, the way in which I would describe it to you is, imagine the last time you were sick. So let's say you had some viral illness, so maybe flu or maybe viral gastroenteritis. Remember the way that makes you feel. Forget the local symptoms, because obviously flu, the local symptoms would be that it would give you a cough that brings up horrible sputum, your throat might be sore, things like that. Those are local symptoms of the infection. For gastroenteritis, it's nausea, vomiting, diarrhea, etc., tummy pain. But think about the way that it makes you feel mentally. It makes you feel tired, it makes you feel grumpy, it just makes you feel not good at all. Those are, if you like, the systemic symptoms of the infection, of the illness. Depression, the best way I can describe depression to someone who's never experienced it is, imagine having those mental symptoms, i.e. the tiredness, the feeling grumpy, the not feeling great at all, the just no sort of will to get up and go. No get up and go is probably a good way of saying it. Imagine that, but without actually having the infection. Imagine you have that all the time, but with no infection, so you don't have the flu, you don't have gastroenteritis, so no local symptoms, just that mental feeling all the time. That is what depression is, and it's incredibly common. A lot of people have that sort of feeling. They feel like that all the time, every single day. And, it will fluctuate. Some days they'll feel slightly better, and other days they'll feel worse. But all the time, their mood and their energy level is suboptimal. That is the condition that we call depression. And at present, we do not really understand why it occurs, but it is incredibly common. A huge number of people in the general population have this. Biomedical scientists are still trying to figure out exactly what causes it, and there are all sorts of theories. If you go on the internet, if you go on health forums on the internet, you will find people spurting out all sorts of theories that they've read and that they're trialing. So, a lot of people think that maybe it's some sort of chronic infection that is making them feel this way, and that's a reasonable theory, because after all, we all know, think of my comparison. My comparison was comparing it to the state of having an infection, so it therefore would make sense for maybe it to be the symptom of a chronic infection that maybe isn't producing any local symptoms. Now, it certainly seems that it's not the chest that is causing it, so most people with depression don't have any respiratory symptoms, so it's unlikely to be an infection of the chest. Other common sites for infection, skin, you can examine their skin, there's nothing wrong often with their skin, so it's not going to be a skin infection. Waterworks will produce symptoms, painful urination, having to urinate more often, so again we can rule out waterwork infection. The general place that people point the finger of blame to is the gastrointestinal tract, because often a lot of people with depression have sort of GI symptoms. They might have chronic tummy pain, chronic diarrhea, things like this, and therefore a lot of people in these positions sort of think that they might have a chronic gastrointestinal infection or maybe some sort of imbalance in the commensals, but these are all just theories, none of it's proven yet. Other theories you might hear, I've heard people blame it on their amalgam fillings, so mercury toxicity. They think that because they've got amalgam fillings, the mercury is seeping into their bloodstream, their mercury level in their blood is far too high, and that's what's causing their depression. And then they ask you to measure their mercury levels, which you can do. It's a very rare blood test to do. I've never ever ordered mercury levels in my clinical career thus far, so I imagine it's quite an expensive blood test to do, but in principle, if you really had someone who really believed that theory, you could prove them wrong by measuring their mercury levels. Other theories I've heard, aluminium toxicity. People think that because they're applying aluminium deodorants, antiperspirants that stop people sweating contain aluminium compounds, and they believe that the aluminium's getting into their blood and causing aluminium toxicity, and that's the cause of their depression. I've heard that one before. What other theories have I heard for depression? Um, all sorts. I can't think of any more examples at the moment. I'm sure more will come to me as we go through the video. But there are all sorts of theories of what causes depression. At the moment, none are more credible than the others. You know, in in videos that I've made previously, I've referenced Harry Potter quotes, and I'm going to do that now. There's a quote from Harry Potter 3 where Dumbledore is pondering how Sirius Black entered the castle, and someone asks him, you know, do you have any theories of how this happened? And Dumbledore says, many, each as unlikely as the next. And that's kind of how I feel about all these theories that you see on the internet about the cause of depression. Now, of course, the theory that the pharmacology textbooks and other biology textbooks push in your face is the monoamine hypothesis, specifically the serotonin hypothesis, that serotonin levels are too low in the brains of people with depression, and that the main reason this theory came about is because all the drugs, well, most of the drugs that work as antidepressants, or we believe work as antidepressants, actually have a mechanism whereby they increase the level of serotonin in the brain. And that's the main bit of evidence for the serotonin theory of depression, the fact that the antidepressants all work by raising, we know, raise serotonin in the brain, and we believe they work, and therefore maybe that's the cause of depression, too low serotonin. But what that theory doesn't provide is an explanation as to why the serotonin level is too low. That, you know, is a massive question mark in the serotonin hypothesis. So really it's just a theory based on the antidepressants. Right, so enough about what depression is. Let's actually now talk about what I wanted to talk about, which is the antidepressants that are used in the UK commonly, and the order generally in which they're prescribed. So, difficult decision now. Do I use my pen and write it in my own handwriting, or do I do it fancily with the typer? I think I'll type. So, first drug that we're going to talk about is sertraline. Now, this is within the class of SSRIs, and I'm just going to use my pen briefly here. So this is within the class of antidepressants called SSRIs, selective serotonin reuptake inhibitors. And it is, in the UK at least, commonly considered the first-line antidepressant. It's considered very safe. Its side effect profile is usually minimal, usually very well tolerated, and it's very safe in overdose. In fact, all of the SSRIs are very safe in overdose. The older antidepressants, such as the tricyclic antidepressants, they were much more dangerous because if you overdose on them, you will likely die. Whereas the SSRIs, it's very, very difficult to overdose on these. You have to take a huge number, and even then, it probably still isn't going to kill you. So they are very, very safe drugs, the SSRIs. And sertraline is generally viewed as being the gentlest of the SSRIs and the safest one to begin with. And the usual starting dose would be something like 50 milligrams once a day. And this can be raised. If it doesn't work, then it can be raised to 100 milligrams once a day, and you can actually raise it up to a maximum, generally, I think, of around 200 milligrams once a day. So starting dose will be 50, but it can be raised really to a maximum of 200. You very rarely see people on doses as high as 200. Generally, you would raise it to 100 milligrams, and then if that doesn't work, you'd maybe move to the second-line antidepressant. So sertraline would be the first-line antidepressant, except in elderly people. In elderly people, the first-line one would actually be a drug called Mirtazapine. Now, this actually isn't an SSRI, and whoops, we haven't really got enough space for it here. Let me just shrink this down because I want this all on one line. So that's why. Font size 99. So let's reduce it. Mirtazapine. So this one is off to the side. So if you've got a young patient, and by young I generally mean, let's say, less than 65, your first-line antidepressant would usually be sertraline. However, if you've got an elderly patient over 65, then the general first line is this drug called Mirtazapine. Now, this belongs to a class of drugs that, can I actually remember the name of? I think it's something like NASSAs. And can I actually remember what that stands for? I don't think I'm going to even attempt to recall what that stands for. I'm just going to embarrass myself if I attempt to do that. But it's in a different class of drugs. This is not an SSRI, but it works in a very similar way. It interacts with serotonin. One of these S's here is serotonin. So it works, it's something to do with serotonin, and it alters, again, neurotransmitter levels within the brain, neurotransmitter activity within the brain. So first-line drug for someone under 65 would be sertraline, first-line drug for someone over 65 would be mirtazapine, and the doses of mirtazapine, the starting dose would be 15 milligrams once a day, and actually it's taken in the night usually, not in the day. So sertraline would be taken usually at 8 a.m, so we'd write OD once a day, whereas mirtazapine would be taken just before you go to bed. OM means once at night. And the reason for that is it's quite sedating, mirtazapine. It makes you tired when you take it initially. So that's the reason we give it at night, to help people sleep. And then when they wake up in the morning, it'll have its antidepressant effect and hopefully its sedating effect will worn off. So it's considered usually quite a nice drug, mirtazapine. Oops, I didn't mean to do that. Doses-wise, the starting dose would be 15 milligrams. It can be raised to 30 milligrams, and then the maximum dose is 45 milligrams. And you do see people on the maximum dose of 45 milligrams. Whereas sertraline, it would be quite rare to see someone on a massive grade dose of 200. Mirtazapine, you do see the maximum dose being used. So, first-line drug if they're elderly would be mirtazapine. First-line drug if they're young would be sertraline. Let's now go to next drug. So if mirtazapine doesn't work, let's say you've raised the dose to 45 milligrams in an elderly person and it doesn't work, you then go back to the first line one for the young people. So you'd then go on to sertraline. So you'd move them off the mirtazapine, you'd stop this one and start sertraline 50 milligrams. Let's say we've raised sertraline to 100 milligrams, it still isn't working. What would be the second line antidepressant? It would be a drug called citalopram, generally. Citalopram is, again, an SSRI. Its starting dose is generally 20 milligrams once a day, although if you want to be very gentle, you can give 10 milligrams. But usually the starting dose would be 20 milligrams, and it can be raised to a maximum of 40 milligrams once a day. Third line drug, if citalopram doesn't work, then we put people generally on a drug called Venlafaxine. Now, Venlafaxine is not an SSRI. It is in a different class. It is what's known as an SNRI, which stands for serotonin and noradrenaline reuptake inhibitor. So it raises the levels of not just serotonin, but also noradrenaline within the brain. And the general starting dose for venlafaxine would be 75 milligrams once a day. It can be raised to a dose of 150 milligrams once a day. And sometimes you see people on higher doses. Sometimes you see people on doses of 225 milligrams in a day. Sometimes that'll be divided up, so they'll take 150 milligrams in the morning and then 75 milligrams at night, or they might take it all as one dose. So venlafaxine would be third-line drug, and as I say, it's in a different class to the SSRIs. It's in this class of SNRIs. Another drug in that class would be a drug called Duloxetine, which we don't generally use for depression anymore. Duloxetine is a drug that is often used now for complicated pain patients, so patients with chronic pain. It's used to try and desensitize people with chronic pain. So people with chronic back pain, for instance, would be a good example, where after you've had chronic pain for a very long time, sometimes the brain becomes sensitized to pain. So even if you just sort of scratch these people, they'll feel that as a huge amount of pain because the brain has become sensitized to pain. And therefore you can try and treat their chronic pain with strange approaches, using antidepressants and psychotropic medicines, such as duloxetine. Duloxetine would actually generally be the last line drug for this purpose. But these drugs can work on that sensitization component. They can reduce sensitization and therefore reduce pain. So they're very odd drugs, but they do have a role in helping with people with chronic pain when there's this sensitization phenomenon going on. So I'll just write that here. So chronic pain, when there is believed to be a component of sensitization. And as I say, it's really like the last line drug for this purpose. The first line drug would be an old antidepressant, actually, within the category of tricyclic antidepressants. It will be the drug called amitriptyline. So the tricyclic antidepressants aren't used anymore as antidepressants. Instead, they're used for this purpose, treating chronic pain where there's a sensitization component. And amitriptyline would be the first line one. If that doesn't work, then you might move it to a different tricyclic antidepressant such as nortriptyline. And then if that doesn't work, you might try one of the gabapentinoid drugs, so either gabapentin or pregabalin. These are drugs that are mainly used to treat neuropathic pain, so pain where it's because the neuron is actually injured that you're getting the pain. So when people have prolapsed intervertebral discs and they're pressing against nerves and you get that sort of electric shock type pain, that's what is called neuropathic pain. And these are the neuropathic pain agents, gabapentin and pregabalin. And in the UK, actually, these drugs have just been made restricted drugs. They've just been made controlled drugs because they are being abused so much, because they can potentiate the effect of opiates. So people were taking them with morphine and heroin and tramadol and God knows what, because it actually increased, because they actually, as well as treating neuropathic pain, they increased the effect of opiates. So they were being abused. So they've now been made controlled drugs. But their main medical use is to treat neuropathic pain, so pain where the neurons are injured. But they can also be used to try and treat sensitization in chronic pain, and they'd be used after these sort of drugs. And then if those don't work, then the last sort of line drug would be duloxetine, or it would be duloxetine. Duloxetine is generally viewed as the last line, but it's another member actually of this SNRI category of drugs. But as I say, it's not often used as depression. Venlafaxine is the member that is used for depression. Now, this is actually where I'm going to end the video, because I'm not going to say anything beyond that. This is the algorithm as far as I know it. In an old person, you start with mirtazapine. If that doesn't work, you then go to sertraline and work your way through this algorithm here, so sertraline, citalopram, and then venlafaxine. In a young person, you go straight to sertraline. You wouldn't generally see a young person on mirtazapine, and then if that doesn't work, citalopram, and then if that doesn't work, venlafaxine. And the reason I'm not going to go any further, what if venlafaxine doesn't work? Well, that's the point that really you refer to a specialist. You then send them to see a psychiatrist as an outpatient, so that's the psi symbol in Greek, which is often used to represent psychiatry. And psychiatrists can then prescribe much, much scarier drugs. So they can actually put people on antipsychotics for depression, whereas I have never initiated long-term antipsychotic therapy on anyone unless I've been told to do it by a psychiatrist. So antipsychotics are drugs that are used to treat psychosis. So when psychosis means, briefly, hearing voices, seeing things that are not really there, so hallucinating and believing that it's real, and it's really quite scary. So what someone once told me, a brief summary of psychiatry, is that anxiety is staying in the house all day, pacing up and down because you're too afraid to go outside because of what will happen if you bump into someone you know, or if you see a dog, or if you get stung by a wasp. That's anxiety. Depression is staying at home all day, sat in a chair crying about how miserable you are. Psychosis is staying at home all day with all the curtains drawn, sat in a corner, hands over your ears, screaming at the voices to stop. And I've always remembered that. That's a brief summary of the psychiatric condition. So psychosis is horrific. It's thankfully, a very rare, well, not a really rare condition, but it's much, much rarer than depression and anxiety. But it does exist. And the antipsychotics are drugs that truly do help psychosis. It is absolutely incredible when you see someone who is frankly psychotic, you initiate them on an antipsychotic drug and they come back, they become sane again. But antipsychotics have horrific side effects. The main one that I use is haloperidol, because we use this to sedate people when they're being extremely aggressive and violent in hospital, but I would never initiate it long term. We only give single doses to sedate people short term. Other incredibly important antipsychotics to know are olanzapine, risperidone, quetiapine, and then the last line one, the one that they use if all else fails, is then clozapine. But they all have horrific side effects. They make it really difficult for people to move. They make it really difficult for people to think. Basically, they work by turning the brain half off, is how I think of it. We all have the ability to think. You know, we're all thinking right now. We have thoughts going through our head. We can imagine things. That's our conscious thoughts. These drugs basically work by reducing your ability to think. They make you sort of foggy, brain fogged, reduce your ability to think. And that's how they work to treat psychosis, because if they turn the thoughts down enough, eventually they'll turn the hallucinations off. So they're pretty blunt responses to psychosis, and they can be used to treat depression, especially, you know, if your depression is driven by your thoughts. You know, if you've got loads and loads of negative thoughts, then turning those thoughts off can sometimes be desirable and preferential to the depression. So sometimes these drugs are used to treat depression, but I would never initiate them for that purpose. They're usually used in much smaller doses than they would be to treat schizophrenia or psychosis when they're used for depression. But really, I would leave it to a psychiatrist to initiate one of these drugs for depression. So we'll call it there. Thank you for watching this video. I hope you have learnt something.